Good. Okay. Well, first of all, as a sort of courtesy, I should introduce myself just a little bit very quickly. As I'm not a clinician, but I head up the strategic projects team. We were set up in about 2009 to lead and facilitate change in the NHS at that particular time. A very controversial project called the Hinchinbrook franchise. Since deep intake of breath, I heard it. But since then, we've had a great time and have been really lucky to work with some incredible people to achieve a huge amount of change, what we think anyhow. It's obviously a small amount in the context of the scale of the NHS, but some really big projects ranging from big integration through to the Friends and Family Test and not least this particular project and meeting Penny a few years ago. There was a complete, a chime with what we were trying to achieve, that of sustainable service excellence in the NHS, achieving more or less. And I think, as Steve Dunn touched upon earlier, the renewable battery, the renewable source within people, and how there was so much to offer within the NHS that just needed the conditions and the help to take it forward. And I think this project is one of those particular examples of just looking inside within and seeing what we can do and so much more for our patients and indeed for ourselves as professionals. So this, I think we have about 25 minutes, am I right? Looking around to Karen and others. If we're just going to do some introductions, I think, obviously you've met Andrew, Penny and Angela, but we have two others here on the stage. So gentlemen, if you could just introduce yourselves to the audience and then we'll kick off with some questions and answers.
Thanks very much, Andrew, and good morning, everyone, or good afternoon. God, blimey, you're going to be tough. God, it's a tough crowd. My name is Pete Moore, and I always introduce myself and say I used to be a patient, but now I'm a person again. And what I do now is I work with the Pain Toolkit, and I'm very much passionate about promoting pain self-management to not only people with pain, but also the healthcare professionals and healthcare teams that actually support us.
Thank you. Thanks, Pete. My name's Alf Collins. It's a delight to be here in Norfolk. The last time I was here in Norfolk, I was 7 years old, so that's well over 20 years ago. And it's a delight to be working with such a wonderful group of people. I'm a clinician in Somerset, and I work with people who live with long-term pain on a daily basis, and I also work a day a week in the Health Foundation, which is kind of a think tank in London. Pete and I thought we'd have just a brief conversation to kick things off, if that's okay. And the kind of focus of our conversation was really going to be about why the conversation needs to change. I think we've had a lot of thoughts in terms of the system and in terms of evidence this morning. But Pete, tell us your views on that.
I think really the NHS was at a crossroads many years ago. Are you all taxpayers, by the way? Well, back in the 90s, I cost you 350,000 quid because I was stuck in the medical model of care. And I had to dig myself out of it. Unfortunately, I didn't have a good GP like, many people here today. But in fact, my GP, it was the days when there was fund holders as well then. But I had to dig myself out the hole by getting myself on a pain management program so I could learn some skills myself. And the thing is, I've got some buddies at the Department of Works and Pensions, and they tell me that 3,500 quid could be more like over £500,000 now. Because those in them days I wasn't really encouraged to self-manage or, in fact I was pretty much a doctor shopper, a therapy shopper. And I've heard today about activating patients, and the thing is, I think what tends to happen with me and other people with pain is that we are actually activated already, but when we jump in to see the healthcare professionals, we actually become deactivated. And it's nothing personal. But that's what happens really, because when I do some work with the Kent Pain team, and we do like pain in the community days, and there was about 60, 70 patients there, and they'd all been deactivated, and because they was all in that medical model of care or waiting to be something to be done to them, And when I started to talk to them about self-management, well, things you've got to do yourself, they didn't like it because it's become a habit that they're waiting for those things to happen to them. So, and the thing is, I think as I say, I think the NHS reached this crossroads many years ago. And I always remember the Paul Burstow, who was the self-care minister before Norman. There's a little video of him. I'm not sure if it's the Health Foundation or the King's Fund, and he said back in 2012, unless we deal with getting people to look after themselves, self-manage, they will bankrupt the NHS, and we will. So I think what you're doing here today around health coaching, promoting self-management, self-care, it's not a choice. It's got to be. You've got to do it. You haven't got no other things to do. So if you're not getting into this sort of stuff, I really suggest that you do, because the thing is, if you don't do it, say there ain't going to be enough money, resources to do stuff. For the what I call the life-threatening long-term conditions.
Before I hand across to the chair, can I just give the kind of clinician's angle on this? Is that just for 1 minute? So, 25 years ago, when I started working with people with pain as a consultant, the kind of messages I was giving people were tell me what's wrong, tell me all the things you can't do, give me your pain, I'll try and fix it so you can live your life. I was going mad at the end of the day because I was living a lie, and the people I was working with kept coming back frustrated and angry that the stuff wasn't working. So I kind of got into health coaching, quite a long time ago now, frankly, in order to preserve my own mental health, number one. And then I kind of started to realise and understand that actually it worked for people with long-term pain and long-term conditions as well. It is a no-brainer. So that's our story. Andrew, back to you.
Okay, no-brainers. So I'm sure there are nonetheless going to be some questions. So can I invite questions from the floor? Do we have any microphones, or do our colleagues have to? Yes, there's microphone people at the back. So you can put your hand up. Thank you. There's one over here already. And if you could just say who you are, and if your question is addressed to any particular individual or just the panel at large. Thank you.
Okay, thanks very much. Hello, I'm Carol Holloway, and I work for Macmillan Cancer Support in Service Development. I've got a comment to make, and out of that comes a question, and any one of you may want to comment on my comment. So when I'm thinking about what we're talking about today in health coaching, the bit that's key that we're talking about today is the personal aspect of it, how clinicians talk to patients. But around that is a cultural context, and that's about how patients live within their families and within their societies, and how professionals live within their professional groups. And unless you get culture change, you don't get a kind of tipping point where all of us begin to think about this different way of working as normal. So there's that cultural tipping point that we need to reach. But around that, there's also structural change that needs to happen, and particularly in cancer services, which is what I know best about. We need to be able to address the anxieties of professionals who are worried that their patients actually can't cope and aren't going to get the care that they need if they're asked to go out and just kind of manage it themselves. So in cancer care, we're particularly looking at, for example, risk-stratified follow-up, so that patients don't go back for regular checkups every 6 months, which we know doesn't actually identify the recurrence of cancer. They need to be stratified in terms of their particular pathway and their particular personal circumstances. But if we're going to do that, we have to change the system to make a very different way of doing follow-up. We also need to make sure that people have a very rapid feedback into the system when they do notice that there's something that they want to get some expert consultation on. So I think as well as what we're talking about here, the personal bit, we've got that cultural change that needs to happen, and we've got that structural change that needs to happen. So I suppose my challenge is not only have we got to do everything that we're talking about today, but we've also got to have conversations with commissioners, we've got to have conversations within the NHS about how do we do this really massive structural change as well. And how is Health Education East of England addressing that in terms of talking to commissioners and that kind of bigger systemic change that needs to happen?
Thank you very much. That's a fairly hefty question, in many respects. I mean, we will be talking, I think that both dimensions of that, of course, are absolutely pivotal to the success of this programme. Without stepping aside from any aspect of that question, I mean, we are probably going to focus a bit more on the cultural dimension this afternoon when we kick off with Matthew Wynne. But so can I just focus perhaps initially, obviously referring, if you so wish, to the cultural dimension, perhaps Penny, put you on the spot to start with, around the structural approach, and having had lots of experience in navigating, if that's the right word, through some of the complexities of our healthcare system to actually achieve what we've managed so far. Would you like to comment, please?
I'd just like to thank you for raising those 2 points and completely agree with you. The reason why we've focused on health coaching today within the wider context, and Matthew will talk about his organisation's approach, is because we feel that there's a particular gap in the personal. But the other two are very, very relevant and important, and the evidence is that we need to integrate that training into a broader system. So that is absolutely the next step. So in terms of case management or care planning or risk stratification or different systems. So health coaching shouldn't really be an add-on. It should be aligned to a strategy for long-term conditions and cancer care, absolutely. So thank you for raising that. I don't have all the suggestions and how to do it. Of course, it will be different in different organisations and areas. Some are much further ahead than others.
Thanks, Penny. Angela, would you like to say anything?
Yes, the House of Care, which I skipped over rather quickly, partly because of time and partly because Sue is going to be talking about it more later on, but it really, it is a way of addressing all the things you mentioned. So the point is, you know, if you get, and I actually do think that the centre, the personal conversations is the place to start. Once you start there, you very quickly realise, as you've just very eloquently put it, that an awful lot of things around that have to change in order to make that happen. And the house, I think I'd just encourage you to go to Sue's workshop rather than explaining, but that certainly does bring in the structural issues and indeed the cultural issues and all the kind of supports that need to be around this new type of conversation.
Thanks, Angela. Thank you very much. Do we have some lady at the front here, please? Thank you.
Hello everyone, I'm a commissioner. I work for a CCG in Essex. Looking at the paperwork, Essex hasn't really taken up health coaching at the moment in the numbers that are further north of the region. I see a room full of clinicians, people signed up. It is a no-brainer. People with public health background know that. People that are working it now know that. What I don't see is a presentation on the financial case for change. So I don't know how many directors of finance are here. Any? Any financial people? Any accountable officers? So what we need to do, I think, is actually place that in the hands of the commissioners. If we're not going to commission it, then we're all at a sticking point.
I think that's a very valid point. I don't know if the panel would like to comment. I suspect they violently agree. Thank you for that in many respects. And I know a bit about the history of this programme, to know the challenge. Pete.
It's funny, thanks Sean. It's funny, when Penny asked me about this event, I said, yeah, but who's going to be there? Who's going to be the decision makers, the ones with the checkbooks? Because otherwise it's the usual suspects again, isn't it? And it's you know, in the nicest possible way, it's just the usual people sort of turning up at these sorts of events. But a challenge for you really, Sean, and all your other colleagues here, is actually go back and talk to the commissioners and saying, look, you know, we want to save some money, so let's get, you know, we need to really seriously have a conversation with Penny and Andy and the rest of the guys like are doing this sort of stuff in Education England, you know. So really, it's not about what we're going to do, but it's about what you're going to do today when you leave here today. You'll have a nice lunch, have a nice cup of tea and a biscuit, but you've got to, you know, what's the take-home message? The take-home message is, what are you going to do? Because by tomorrow you'll be tied up with other things and bits and bobs, but you've got to make a mental note, say, on my to-do list is to go back, have a conversation with people like Sean, who's got the checkbook, Say, how are we going to help people in our community move from patient to person? Because it's unsustainable. Keep doing what you... What's this, that one about the definition of insanity? Keep doing the same old stuff and expecting different results. Are you crackers? Because what we keep doing is the same old stuff all the time.
But Penny, you've got the scars, so... Thanks,
Yeah, I
Pete.
have got the scars. Thanks, Sean. Very good point. I think Karen would say that we've sent the invite out to all CCGs across the east of England. And but I think I now work in Colchester Hospital. I'm Director of Service Integration there. And I would say that actually this is something that as a provider we need to do. So it's not just about commissioners, it's about being a provider. And I think that a lot of the clinicians that have been trained have been, they've given a lot of time to the programme. It has been funded up until this stage, and now that funding has stopped, so it is up to other organisations to take it up. But we have been lobbying at many different levels nationally, Health Education England, East of England, CCGs. This has been funded from a leadership pot. So there's lots of different sources of funding. CPD funding, in your own organisation, I think is not always spent. So it's not just commissioners, but they do have a key role, and we did ask them all.
Okay. Quick comment from Alton. There's a lady on the front here.
Yeah, just very briefly, and it is picking up on Stephen Dunn's comment. People at high levels of activation, at activation level 4, cost at 6 months 8% less, and at 12 months 21% less than people at low levels of activation level 1. Supporting people on their journey of activation will support the business case.
Okay, thank you. Please.
Hi, my name is Liz Buxton. I'm from Anglia Community Enterprise, and I'm really proud to say we've got nearly 5 accredited train-the-trainer health coaches. On the point of commissioning, we've been really supported by our commissioners, and we have a health coaching sequin, which has helped me bring it through the organisation. And we've done that at sort of lead level, sort of band 6, band 5, but we're also going to introduce it throughout the entire organisation. So commissioning has supported us to drive this initiative.
Thank you very much. So I think there's some degree of encouragement. Is there a question at the back there? Yes, thank you, gentleman there. And one over there. Okay, thank you. Got 2 to come.
Hello, I'm Simon Downs. I'm Associate Dean for, I can't say HEEU, so the Let Be here, and I'm also National Clinical Lead for Apprenticeships. I do get very depressed. I led a project where we allowed people to die in their place of choice, and the percentage went up from 17% to 70%, but we couldn't get any funding when we went to the CCGs or any other organisation to continue with this work. And I feel exactly the same about this work. The work on the consultation started in the 50s, and we were only really beginning to see the fruit of all that work. So why can't we do some long-term planning for a change, look at something like this, accept the fact that it's going to take years for the cultural shift, but actually patients will be better off. I believe that doctors will be better off in terms of their mental state, if there are any left. And why can't some organisations just invest for the future rather than accepting the political view that we need a short-term fix?
So if I take that question as, why not? I don't know if the panel want to comment. I think, from my perspective, or our perspective, the economic imperative that sits behind so much of self-help and the need for the populace to start to take control of their healthcare against a backdrop of increasing economic pressures on their public services, not least the NHS, I would hope starts to push things forward. But I think as it's already been articulated by the panel, it's word of mouth, it's getting that message across the system, and above all, getting our public to understand their role in this. And I think, that's a huge leap, trying to get our patients to start pulling and requesting this information, requesting this responsibility. That's the big change we're going to need. We won't going to manage it ourselves, no matter the size of our organisation. I mean, Angela, you commented that shared decision making has been on your particular agenda for a long, long time. I mean, do you have any just general observation as to the reluctance of the system to respond or move forward?
Well, I agree with the questioner that the NHS has a terrible tendency towards projectitis, towards doing things for a short space of time. The Health Foundation, for example, has been doing quite a lot of reviews recently on what how you can achieve change, and I think they say that you must give it at least 7 years. Well, you know, if you only have funding for 1, or if you're really lucky 2, you haven't a hope. And then we've moved on to the next fad. I think that a lot of, the good news, I think, is that a lot of these things that we're all talking about have come together much more now. So in a recognition about what the consultation needs to look like, the kind of support that's needed, the kind of imagination that the commissioners have got to exert in order to really get behind it. Also, leadership from the top. NHS England needs to do much more, I think, to give this a strong steer. I believe they're about to produce a report which will give it a stronger steer, but my goodness, it's taken a long time to get there. We have been talking about it for ages.
Thank you, Angela. And I think we're moving forward. So the lady's been waiting patiently at the back, and there's somebody just further near the front here. Please.
Hello, I'm Sally Quilligan. I'm lecturing clinical communication at the University of Cambridge. I think I would like to talk about the importance of actually getting this into undergraduate education. At Cambridge, I think we're quite lucky in that we have had a very well-developed programme for the last 8 years, which has included a small amount on health coaching and certainly addresses both the bottom 2 areas that you were talking about, so the skills area and also the mindset. I think we are one of the most developed programs in the country at the moment, and I know I left nursing education because I felt I couldn't address this in the way I wanted to within nurse education at the time. So it's a comment about the fact that culture change needs to also come from the bottom in terms of starting with the students. It's also a question to the panel, really. At Cambridge, we're devising a new curriculum. There is a strong push for it to go back towards a more doctor as scientist emphasis. And I would really value a comment from the panel that I can take back to the curriculum group. Thank you very much.
Thank you very much. That sounds very encouraging. I think, as an observer, I sometimes think we're adding this in further downstream when it should be an integral part of the formation of our clinicians of the future. But perhaps that'll come as you've been touching on. Would anybody like to comment on?
Yeah, well, my background originally is in medical education as well, so it really tugs at my little heartstrings around that. I think we need to be doing it at all levels at the same time to actually create the culture shift that people are talking about. It's an imperative in medical education to get people to start off on the right track. We all know that people start medical school more compassionate than when they finish. We know that there are lots and lots of bruises about the process which actually knocks that out of people and makes it a very mentalistic experience. But I can say that from the people who've been involved in actually attending the programs in this particular part of addressing some of those issues, none of them have said that they plan to sit in a room and watch people cycle through every 7 minutes and sit there and tell them what to do. That wasn't why they got into healthcare. People get into healthcare because they care about people, and I think that needs to be nurtured and held and actually encouraged all the way through the journey of healthcare professionals.
Thank you, Andrew. We move on then to the next question, please, lady there at the front, or near the front.
Thank you.
You might need to shout.
Thank you. Can you hear me now? Yes. Oh, probably didn't have it close enough to my mouth, sorry. My name's Joanne Fillingham. I am the Regional Rehabilitation Lead for Midlands and East, working at NHS England. And I was really pleased to hear this morning, somebody mentioned, I can't remember whether it was you, Penny, or Caroline, about AHPs and that potentially this isn't new to AHPs. certainly it isn't. I think coaching is a tool that AHPs have used for some time, and I'm pleased to hear that some AHP colleagues will be presenting this afternoon in the workshop. The reason I just wanted to highlight that is coming back to the financial question, is that I think there are probably lots of examples out there where coaching is used in pathways where there are very clear examples that there can be cost savings. So if I can give you a couple of examples that I know of. So I don't know whether you've heard of StartBack, which is a risk stratification tool for lower back pain. That's a tool that's now being used. And what that's shown is that, so it stratifies people into 3 levels, and at the lower level, a coaching style is used instead of face-to-face treatment. And that's shown to give a £35 saving per patient and over £600 societal savings. So that's just one example. Another example is I know dietitians use coaching a lot, particularly in adult weight management. And I know the Waistline service in Staffordshire have got lots of examples of how, by using behaviour change methods and coaching, of not only had an outcome in clinical effectiveness but cost effectiveness. So I think there's lots of learning out there to be done that we can use to kind of support taking this health coaching concept further forward. So looking forward to the rest of the day.
Thank you very much for your observation. I think as a general point, sorry, yes, Penny.
AHPs, we've got quite a few here from, we've got 2 workshops, community services, and I think that they've been absolutely brilliant. And actually, as a GP working with and running programs, multidisciplinary programs, we run multidisciplinary programs, one of the key learning things is learning and respect for our colleagues in other professions. I really have enjoyed and have a huge admiration for our AHPs that we work with and the nurses as well. So that is a sort of spin-off. I'd like to celebrate and congratulate them.
Thanks, Penny. Alf, do you want to say?
It's really just an additional comment, and it really goes back to Angela's systematic review. There's quite a lot of work, as I'm sure many of you know, with peer-peer coaching going on across England at the moment. So Age UK is doing a lot of really good work in Cornwall, in Dorset, in Kent. So I think it's something that we shouldn't forget. Incredibly important that we support clinicians on this journey of change, also recognising the importance of peer-peer coaching and social networks.
Thank you, Al. I was cutting our panel off there as I was looking at the time. But is time for one more question? If there's any more questions from the floor, please. We've questioned you out, have we? I think some useful contributions there. Any final comments from the panel here based on the useful questions and observations we've had?
Am I allowed to ask Alf a question?
Well, I think so, yes. I think.
Not sure.
Alf is also doing a fantastic, Alf does fantastic workshops. He's doing a fantastic workshop on patient activation. But in his previous role, he was lead of co-creating health at the Health Foundation. So Alf, what are the key lessons that you could tell us from your experience of co-creating health, embedding health coaching in the East of England?
So yeah, in the Health Foundation, we ran a programme that cost £9 million called Co-Creating Health, which was trying to embed the principles and the practice of self-management support into health systems at scale. We learned an awful lot. We learned an awful lot about how not to do it. What I learned, big lesson, was system preconditions. So build the system preconditions, and frankly what that comes down to is build the house of care in order for the skills to sustain and embed and spread.
Thank you very much. Well, I think that's an excellent point to finish on. Thank you very much for your contributions. As you say, we're